It's Robert. It's from Emsom. Starting to see familiar names here. I know I was pushing for this choice of making everything a webinar just for easier coordination, but it does mean I feel like I don't have much insight into what people are thinking about. So hopefully this session on over the weekend will be more informative.
Yeah, we could. I'd be down to see how it goes if we turn something into like a regular Zoom meeting, make it really engage. I've done that previously. It's like actually works out pretty well. Sometimes speakers like it
Yeah,
to keep it like
I
very
think
engaging.
for smaller groups, yeah, but it was so wildly different, some of the attendance across the series so far. Hi, nice to see
Hey,
you again.
Hi, Shreya.
you. How are you?
Good. Thank you for making the time. I know it's a busy time always at a startup.
Yeah, no problem. Thanks for having me.
Hi, Shreya. I don't think we've met, but I'm Akash. I'm part of the SHDC team. Great to have you
Hi.
here.
Nice to meet you.
We can wait a few minutes for people to trickle in. For attendees, I'm just going to share some links to our website and the upcoming events, just so everyone is up to date on what's happening.
We had a more live engagement in the beginning of September, and I do think the school schedule probably affected that. And then since then, I get this piecemeal like Slack, LinkedIn, etc. Can you send me the recording? So it started to become more async, which I think is part of offering recordings, but we didn't know how to schedule for all the US time zones. So I kind of just picked times based on speaker availability and our team's availability. So that's how we ended here on a Wednesday.
Makes sense.
Yeah. And you're across multiple markets. So I'll have more questions for you around all those logistics, but I think that's always one that I'm not sure how all the operations actually work when you're over so many different areas. Mm. And then I was telling Akash right before this, like I'm actually talking to a startup that does something related to SDOH and just general access to healthcare. And so a lot of these sessions have been really interesting to me to ask some of those questions of how people are actually approaching this. So it's been good for my learning, if nothing else.
Yeah, that's great, Julia. This is it's an exciting project. I know it takes a lot of work on your guys' part as organizers to get it off the ground. So thanks for choosing SDOH as a focus.
It's definitely a year one, and Longsha, who couldn't make it today, unfortunately, but he'll be on some of the other ones. The plan is to go global in future years. I was already trying to tighten the scope to something more manageable in year one, and starting with kind of the US healthcare system and our challenges within the policy here. But yeah, we're testing things out, and this open learning series was a way for us to kind of gather lessons learned that we wanted to hear about. So cool. I
Yeah,
think we're
I think
probably
that the US healthcare system is ambitious enough. Meeting challenge. Before we jump in, you and I had gone back and forth via email, but as you guys talk through the framing of the challenge, is this a good time for me to share any comments about the structure, or should that be async?
I think we can do async, or we can, and I'd like to get Longsha and some other people that are in the planning team to talk through it and the different ideas I might have on how to improve the structure of this going forward. Um, so maybe we can find more time live or async, the rest of the team.
Yeah.
Okay. Okay. I think we're probably good to start for now and let people trickle in.
Yeah, sounds good. We can get started. So thanks everyone for joining. We're excited to have another learning series today. You're joined with Shreya. So really excited for today. In case anyone wasn't able to attend previous events or is not familiar with us, this is Stanford Healthcare Design Challenge. So this is a new type of health design challenge or kind of competition based out of Stanford. And we're really focusing on translating ideas into real world health innovation. So thanks to Julia, who's taken lead on organizing a lot of this and making today happen. I'm Akash, also part of the organizing committee. Just to sort of calibrate in terms of where we are, the whole month of September, we've been hosting programming. The point of this is really to help any participants get up to speed on what we're all about, understand more about the healthcare system, and especially learn more about kind of the topics in healthcare that are very pertinent to our specific prompt in SDOH. So I think today's event is really so focused on SDOH, and I think that's going to be really great to help people think about different challenges and solutions as it pertains to the prompt. And to really flesh out what our prompt is, we're focusing on SDOH this year. So really, as it stated, design a financially sustainable and scalable solution tailored for vulnerable populations that effectively addresses their social determinants of health needs to enhance engagement with healthcare and improve health outcomes. So you can scan this QR code, and our website has more kind of exploratory thought questions to help you get started thinking. And I think probably nothing will be more helpful than today's session with Shreya. So really excited for that. Super briefly, just want to cover the application. This is due at the end of the month, so there's still a lot of time, but something to start thinking about. What we're really looking for is, just the right team. Who are you, and what kind of skills and understanding do you bring to the table? What have you learned about, SDOH and healthcare in general? Why do you care about this issue that you're proposing? And we want to see some. This doesn't have to be very fleshed out, but it'd be great to get kind of some idea about what you will tackle and how feasible it would be. So again, here's the QR code, so please scan that and you'll find more details on our website. And lastly, just want to really quickly cover judging. We have a panel of people who have really like decades and decades of experience at from different angles, whether it's payer, policy, technology, regulation. So we have a really all-star lineup of judges, and what they're going to look for in potential solutions is understanding a problem. Is it clear that you really understand the problem that you're tackling within SDOH and the prompt? Solution value, so what is the magnitude of impact and total patient population that you will address with your solution? Feasibility of implementation. Again, at SHDC, we're really focused on translating your ideas into real-world impact. So how realistic is that? The fourth one is overall presentation. So just, is it communicated well? Is it easy to understand? And finally, product differentiation. So, is this something new, novel, unique that may not be the obvious decision, but you can really explain why it is the right way to go to solve the problem you're thinking about. And I'll hand it off to Julia to get us started with our amazing speaker.
Okay, thank you, Akash. So I'm very pleased to introduce Dr. Shreya Kangovi, who I met probably 4 or 5 years ago. And when I looked up how much progress had been made since then, I really loved the structure of seeing like some of the early indicators back when we were in person and able to talk to different members of the impact team and some of the community health workers that worked with her, all the way to now where it's now scaled across multiple markets and has had an impact financially, clinically, socially on the populations there. So Dr. Kangovi is a physician by training and has moved into a full-time role with Impact and building on a lot of the progress that's been made with a determined, like with an ROI for payers, as well as being able to share this impact of investing in community health workers more broadly in a policy sense. So very excited to hear from her. And if you have questions, put them in the chat or the Q&A, and we'll be triaging them over the talk.
Thank you so much, Akash and Julia. It is really a pleasure to be with you today. It's so exciting that the best minds, I think, of your generation are really trying to tackle fundamentally what is injustice. So before I talk about impact, let me introduce myself briefly and just give you a sense of who I am and some of the beliefs that have driven this work. Again, I'm Shreya Kangovi. I'm the CEO of Impact Care. I have always been pissed off about unfairness. And I also really appreciate stranger love, which is when people don't know each other that well, but they take care of one another. And I think those two values have drawn me toward community health workers because these are people with lived expertise of hardship and injustice, but they use their experiences to help others. Something that I think is a really important thing for you all to grapple with in this challenge is what is health inequity and what causes health inequity. And there's a really beautiful social science research paper that came out in the mid-90s by two researchers, Bruce Link and Joe Phelan. And they really argued that inequity isn't just an imbalance of disease, but rather it's an imbalance of power. That, it's not just, oh, those people over there have more heart disease. And look, if we just gave them more pills or more primary care visits or even more vaccines, we could level the playing ground. Health inequity comes from a constrained set of behavioral choices, a limited set of living conditions, and a lack of voice in the structures that shape health. And so you can't solve for health inequity through clinical care, and you actually need to make sure that power changes hands. That is really a pretty critical framing. The other thing that's just a philosophy that I think is very deeply held, and I just want to make sure that I'm conveying at the outset of this conversation, is the concept of nothing about us without us. And this is what I worry a little bit about with this design challenge and with a lot of the interest that's coming into SDOH. There are a lot of people who may or may not have any lived expertise of the social determinants of health. We may be like research experts, maybe, have really a tremendous amount of, academic and clinical credentials, but haven't lived through what it feels like to go through some of these challenges and injustices. And people who have gone through it are always really the lived experts, and they really need to be centered in any good design starts with end users, but particularly when a power imbalance is at play, it's really critical that these individuals are well represented in not only the design process, but not only the outcomes, but the design process itself. So let me pause there. My style of presentation, I like to make this conversational. I know we have an intimate group today, so let me see, Julia, Akash, do you have questions, or are there folks in the audience who want to put in some questions in the chat just about those core constructs?
We can also try to spotlight the people on the panel today, and then they can stay camera off if they're not in a place to do that, but that might be easier to have people engaged.
Yeah, if folks have questions, please use the Q&A tool or put your questions in the chat, and we can, as Julia said, we can have you come off mute and ask the question directly.
I guess the main question.
Okay.
Sorry, I'm trying to figure out the right way to phrase it. I guess I see it as two parts with designing in healthcare. There's always understanding that user perspective and engaging them, but being able to translate that to a payer or someone that is willing to financially get that idea off of the ground. So how do you balance those two I'm assuming not every channel partner or not everything is a community-based organization. Not every payer has the lived experience to understand where it's coming from. So how do you balance those two with the user and the buyer?
Yeah, they're different stakeholder groups. This is a triangular design process where the designer has to engage two different sets of stakeholder groups. One that has lived expertise of the fundamental problem that they're trying to solve, and the other that can benefit from the solution financially in order to sustainably finance it. I think we err way more toward making it, either just a unilateral design process where we lock ourselves in a boardroom, ask a question that we come up with and come up with some answers, or a linear design process where we're engaging with payers, but forgetting about the people who have this problem and who know how best to solve it.
Okay, we have a specific question from Sai that's around how do we get a better perspective of end users if we don't have those lived experiences?
Yeah, I think you have to go out and ask people to talk to you and ask for help. And I'm sort of like laughing about it, but it's not easy, it's embarrassing. And, asking for any input when you're a designer is a skill that you have to pick up. But it's like being an investigative reporter. You just go and do it. And I'll talk about how we started Impact. But as a spoiler, the way that we started Impact 15 years ago at this point was we went out onto, well, first of all, it was myself and a community health worker partner. So partnerships really matter. So make sure that, this isn't just, okay, I'm in control of the process and me and my privileged friends are going to go out with a microphone and ask people questions. That's fulfills the, that checks the box of end user engagement. It does not check the box of power transfer. So make sure that there should be an end user in your seats, Akash and Julia, in especially when power is such a critical frame in the design challenge itself. I really would, applaud you to, even at this stage of the game, just be like, who is a community partner that represents this lived expertise that we can get in our planning team? Who can we get in the judges circle? So it really has to be baked in at every level. And same thing for the design teams. This isn't just, go out, ask people questions. It's who can I ask to partner? And what can I do to make that partnership possible? Is it paying for transportation? Is it, a stipend? Is it something to make it feasible for people from different walks of life, especially the people who have lived expertise, to show up and, not only have a voice, but drive the process. Does that help to answer the question? But, so back in, in my story, as I'll double click on later, I was lucky enough to meet an incredible woman named Tamala Carter, who was my partner in the early formative work. We went out onto porches and shelters and bedsides, and we interviewed 1,500 people in West and Southwest Philadelphia. And that's how we built Impact. So it's important. We learned a lot.
Thank you for sharing that. That's the scale of that is crazy. And I'm sure that informed a lot of the ongoing work since then, those original interviews. I think something we're looking at in this distributed challenge format is that if people are coming from all across the country, they're all going to have different challenge partners, or not challenge partners. They're all going to have different potential partners in their area of interest, rather than us proposing a specific area within SDOH for everyone to look at. And that would be something that would be great in an application, is which community partners have you approached? Have you understood their problems? How can you help?
Exactly. Yeah, this is super fun. And I just want to shout you guys out because, true designers are always about hacking their own design. You guys are the designers of your design challenge. This is, I think, day one of launching it. And here you are being open to, how you can even make the construct better. So that's super, super exciting. But I don't think a distributed challenge just takes away either the feasibility or importance of making sure that this is as community partnered and centered as possible. So that's fantastic. So I think, that's a little bit about just who I am as a person and some really core values and philosophies that you will see really spilling into the content. If it's okay with you, I can take over and just share some slides. And then we'll kind of get to where we want to go here. Are you able to see?
Okay. Yeah, we can see it.
Excellent. So as Julia mentioned, Impact Care is a public benefit corporation that we spun out of the University of Pennsylvania about 13 months ago. We jokingly call ourselves the 15-year-old startup because even though Impact Care is relatively new, it is, as an organization, Impact as a model has been around for 15 years. So I am the CEO of Impact Care. A little bit more just about my professional background. I'm a primary care doc. I have seen patients at an FQHC for about 15 years. I'm also a socio-behavioral scientist. My journey and the Impact journey started at the University of Pennsylvania, as I mentioned, where my team and I really helped to build a lot of the evidence base for community health workers in the United States. But one thing was that we were really interested in not only answering the question, can community health workers do magic and move the needle on health outcomes, but how can we enable community health workers to do magic consistently at scale? And impact is the answer to that second question. We really have been careful to not only write a research paper and leave it on the shelf, but to build an end-to-end infrastructure model that includes all of the inputs like strategic planning and hiring and training and technology that organizations that range from small grassroots community-based organizations all the way up to Kaiser Permanente, that they can use this framework and adapt it to their local constructs and local needs without having to reinvent wheels and to be able to make use of evidence-based practice. So that was what we intended to do when we created Impact. We then tested it in multiple randomized clinical trials and showed that it does move the needle on things like health, quality, and cost. And on the basis of those outcomes have been able to scale out to the point now where we are the most widely used community health worker platform in the United States. Have an amazing team of leaders. As you all know, design is such a multifaceted process. So solutioning is really about the team at the table. And you can probably recognize that these are some of the luminaries in their respective fields. So let me just do a little bit of level setting about who community health workers are and why they are so critical. And I think it'll be really clear, especially in the context of the beliefs that I laid out at the top of the hour. Community health workers are trustworthy people who can deliver magic for their communities. They meet people where they are, both literally and figuratively, and they can provide, tailored social support, care coordination, navigation, and coaching to help them meet their own goals. Community health workers, there's a who, a what, and a why. The who is, as I mentioned, there's two components. Number one, they have shared life experience with the people they serve. You'll hear me saying that over and over again. That's a really critical theme. They've been there and they get it. That could be that they come from the same geographic community, because in the US, geography is such a proxy for things like income, sociodemographic background, linguistic background. Or it could be some other type of shared life experience like veteran status or incarceration status. So number one, shared life experience. Number two, trustworthiness. Because not everybody from the community is for the community. And so you have to pick the best among them. What makes somebody trustworthy? As a social scientist, this is a question that I was really fascinated by. And it turns out that it's things like empathy and non-judgment and listening and reliability. So that's the who. When you think about community health workers, you're asking yourself, do they share life experience and are they trustworthy? Then let's talk about the what. Community health workers, as I'll talk about in a moment, have been around for hundreds of years. And so the best practice varies widely. There are unfortunately a lot of, community health worker programs that aren't effective because the what is the wrong what. And one of the most common things that we see is when community health workers are doing very discrete point solution, checkbox, screen, and refer. Mrs. Jones, do you have enough food to eat? Here's a number to a food pantry. Are you being abused at home? Here's a number to a shelter. That approach comes from a very reductionist mental model of the social determinants of health. And that's another caution to you all as designers of this challenge. Somehow along the way, when we started talking about social determinants of health, I think there was an awareness that they were really the structural determinants of health, the socio-political determinants of health, things like, incarceration and racism and, loneliness and, trauma. Those were fair game. And those are a really, really important part of the problem that we were trying to solve. And then somewhere along the way, it got very over distilled to just resource needs. And that's a huge miss. We did another study where we interviewed about 50,000 people and we asked them, what makes it hard for you to stay healthy? And they answered in open-ended ways. And most of the answers were really nuanced things, like they needed social and emotional support. That doesn't mean referral to behavioral health. That means I wanted somebody to go for a walk with me, or, you know, I had this funeral and I wanted someone to go. I needed to reconnect with my mom. I haven't spoken to her for a while. Another area of need was advocacy, you know, recognizing that people didn't have a voice in their healthcare or their other macro processes, and so on and so forth. A very small slice of the pie, about 14%, talked about discrete resource needs like food, housing, and transportation. And even those didn't really feel like a referral to a CBO was going to be the thing that helps. Certainly that's part of the puzzle here, but we need to be thinking beyond that checkbox. So in terms of the what, in the impact model, what community health workers do is meet each patient and get to know them as a person. They'll say, Julia, tell me your life story, you know, and in the course of that conversation, they'll be like, what do you want to do in order to improve your life and your health? And you get to say, you know, I haven't spoken with my mom for 5 years. I need to make that relationship right. I'm getting some eviction notices. I have no idea what to do about that. And in between everything, I haven't had any time for myself. So they'll sit down, help you write that letter to mom. They'll go with you to check out low-cost rooms for rent. And in between, they'll be like, do you want to get your nails done? Like, I have a friend who does, you know, nails, and I'm sure she can hook you up. So that's, you know, my mental model of, you know, who community health workers are and what they do. I said a lot. Let me pause and see if you guys have questions or if anyone in the audience has anything that they want to shout out.
I have such a tactical question that feels reductionist in its own way, but it's like, how long is that initial conversation? Because I find it hard to box interviews into 60 or 90 minutes when you're trying to have an open-ended conversation that feels more personal than just running through a standard list of intake questions.
Yeah, it takes as long as the patient wants to talk to you. You know, sometimes these take a couple hours. It's really about how long they have. But the broader question that you're asking is about, you know, again, what is the mental model of this community health workforce, who they are, what they do, their caseloads, their structure. If you have a community health worker program and community health workers have caseloads of 1,000 people, they're not gonna be able to do anything meaningful. They're just checking boxes. So they do need to have caseloads that really are commensurate with the type of trust building work that you are asking them to do.
So what's the typical caseload
Panel
of
size.
a impact
Yeah,
panel size?
yeah. On average, over the course of a year, an impact community health worker will serve about 75 patients. This can range, you know, it depends on the goals of the program. You know, some programs are about, you know, hey, let's provide short-term support and just stabilize somebody, or let's help them transition from, you know, hospital to primary care. But if you're really trying to move needles like the ones that we will show in a minute, you need to invest in that time.
So what I'm hearing just broadly is right sizing the intervention to the actual intervention scale in a way, and trying to right size the resources to that. Okay, we have a question here from Naquan.
And I'll just add, like, you know, the right sizing is a part of it, but no matter what the size, you can still have the philosophy that I just mentioned. So even if it's like a, you know, 3-hour intervention or a 1-week intervention, talking to people as people and doing a lot of listening instead of checkboxing and, you know, I'm going to tell you where to go and what to do, you have time for that.
Go in open-minded with how you can help. And this question from Naquan might be answered in your later slides. So that might be something I want to address later in a slide.
Sure. So I see a question that says, you know, how do you go about getting people to pay? And so I'm happy to talk about that journey. And we can go there next. So I wanted to start by just explaining who this workforce is, because I'm definitely biased, but I don't see any kind of SDOH solution that doesn't involve community health workers. And the reason why is, again, if you want to address inequity, it has to be about transferring power from an entrenched power structure to the communities that we serve. And community health workers are the best among us, you know, especially among the communities that we are serving. So they're the recipients of power, you know, in this framework. And they are able to address the social determinants of health in a really holistic way. Okay, let's talk about the journey, and this is where people can kind of jump in with questions along the way. So yeah, I told a little bit of this, but it started in 2010 with our porch tours. We were out on porches, shelters, hospital bedsides, talking to people, and mostly doing a lot of listening, asking people, what made it hard for them to stay healthy, what should we be doing differently to help. And we learned a ton. And I think this might be a good opportunity for me to remind folks about the language that we sometimes use here. I think we sometimes talk about individuals who face injustice as vulnerable. These people aren't vulnerable. They're resilient. They have actually faced probably way more challenges than privileged people, and they have a ton of answers. And so let's just be careful of savior thinking. That's a very rampant problem. And especially when we're solutioning, we just want to make sure that we kind of recognize that, folks who have experience of the problem that we're solving, even if it's one of, injustice or health inequity, are by no means vulnerable. In fact, they're the resilient ones, they're the experts, and we need to be kind of approaching them with that. So when we did that, we learned, a huge amount. There were three main takeaways. Number one, this is before people were talking a lot about the social determinants of health. And so people said in these interviews that there were real life issues that were making it hard for them to stay healthy. And that's the things that we call the social determinants of health now, the loneliness, the discrimination, the intergenerational poverty, the trauma. And they wanted support with those real life issues. So that was number one. It wasn't about like necessarily the 15-minute office visit. It was everything that happened, in the rest of their lives. Thing two is they wanted that support to come from someone to whom they could relate. Yes, there were nurses and social workers and case managers. Oftentimes they meant well. Sometimes there was frank institutional, racism or classism. But even when there was all good intent, sometimes folks who came from a totally different background didn't have a clue how to solve some of these problems. Did you know how to, have you ever been in a situation where you had to choose between bus fare or, medications? How do you navigate when your utilities get cut off? These are practical problems, and you want someone who's an expert in solutioning there. Thing three is that people wanted to stay in the driver's seat. And this goes back to this, oh, those vulnerable people over there, I have to tell them what to do and I have to help them. People are smart. They know what they need. They just need a little support and some resources to get it done. They were sick of being told what to do and cycled through systems, and they wanted to make sure that they were driving. So when we heard those lessons, first of all, it became really clear that community health workers were part of the solution. They were essentially describing community health workers taking an empowerment framed approach. And so that was a really great tip, and it allowed us to do step two of our design thinking, again, back in 2010. And it's so relevant because we set out with a very similar design challenge to what you're trying to solve here, which is why, Julie, I was kind of, texting you earlier about, make sure that you are asking a question that is novel and that is at the edge of what is known, because there's a lot of overlap, and the question as you guys are framing it is quite broad. And so let me just pause for a quick question that came up in the chat if you guys want to say it out loud about the end user interviews. Do you want me to read that, or do you guys want to read that?
Oh, Akash, did you want a spotlight? No problem.
Yeah, let me do this. Let me find it.
Sorry. He's I'm assuming, okay, being on camera since he asked the question earlier. There we go.
Hi, can you hear me? Yes? Okay, excellent.
Yeah.
Thank you so much for being here. And I'm also a fellow Quaker, go Quakers. I was wondering, how did you develop your interview guides for customer discovery? We talked a lot you talked a lot about shifting power when really trying to address social determinants of health and vulnerable populations. Are there any validated instruments that you recommend we use to help us give a louder voice to vulnerable patient populations when conducting these types of interviews?
Yeah, thank you so much, Naquan. So we can, a couple of clarifications. This was a conversation guide. It wasn't a closed-ended validated instrument. And just for the non, research nerds out there, there's qualitative research and then there's quantitative research. Qualitative gives you, words and it raises hypotheses. Often quantitative research gives you yes, no numbers, and it, helps to prove or disprove a hypothesis. These were hypothesis generating qualitative interview guides, and they've been published. Actually, the same ones that we used back in the day to have these conversations are on our website, which I can put into the chat in our published work, and you can help yourself to using them. Does that answer your question?
Yes, it does. Sorry for the delay. I'm having issues with turning on and off my audio on my computer. That's very helpful. Thank you so much.
Yeah, no problem. The other thing is, make them your own and just make sure that you have a community partner to help you with that. Tamala and I wrote out these interview guides. We did a lot of foundational research, and that's going to be the moral of the next slide, but you can tweak them. Okay, so we listen to end users. Thing one that you should always do in a design challenge, listen to end users. Thing two, find the edge of what is known. So as soon as end users started to point us toward community health workers, I was like, okay, let's stop right here. I'm going to lock myself up for 8 weeks, which crazily enough I did. And let's read every single article ever written about community health workers, because you're not having an idea right now. Like the chance that you right now are having some brand new idea that no one's ever thought about is infinitesimal. So you have to recognize that. Like that's a huge waste of time when you kind of come up with something and pretend that it's novel when it's not. We had this benefit of knowing that community health workers have been around for 300 years. There has been a lot of smart people, tackling this question of how to enable this workforce. Let's ask them what they've learned. So I literally read every single article ever written about community health workers. I also interviewed a lot of the people who had been working in and running these programs, both internationally and domestically. And that was so critical because first of all, and I was really obsessed with answering the question, why aren't community health workers already prime time in the United States? And what do we need to do to enable magic with consistency? In other words, like what messes these programs up? And I was expecting to hear, okay, it's just lack of funding and it's lack of political will. And that was there, but actually it was more so nitty-gritty implementation factors, super high rates of turnover. And when you dug into that, it was like, well, that's because there's no mention of hiring practices. Everybody talks about how to train community health workers, but nobody talks about how to hire the right people in the first place. And that's silly. That's the way we think about human resources, by the way. In healthcare, we think it's all about training. How do you become a doctor? You go to medical school, how do you become a nurse? You go to nursing school. But there's really HR and hiring get overlooked. So that was like, yay, that's a great opportunity to sort of hack that system. The next thing was that there was not a lot of just infrastructure for community health workers and supportive supervision. Like people were asked, to do whatever, they didn't have a lot of guidance in their workflows. As you mentioned, Julia, there's no limits to, caseloads. People didn't often even report on caseloads. There wasn't a lot of, information about paying a living wage, having career ladders, all of those pieces. So we had a laundry list of historic problems that if we could solve, we could really build a better mousetrap in terms of a community health worker program that could have better outcomes for patients, but also for community health workers themselves. And that's essentially what we set out to do and have, gone a pretty good ways of the way toward. I'll talk more about what the mousetrap is, but first, bottom line up front, these are the outcomes. When you build a community health worker program with the right inputs that solve for a lot of those historic challenges, it works. We've demonstrated across 10,000 patient months of clinical trial data and 5,000 plus patients in real world PCORI funded demonstration studies that community health workers can have high rates of engagement. They can move the needle on quality, move the needle on chronic disease and mental health. They have great experience for patients, and they can reduce total hospital days, increase primary care. And that we then took those randomized control trial data and built them into an economic analysis that was published in Health Affairs a few years ago that demonstrated a $2,500 annual net savings that was realized by the payer, in this case, the Medicaid payers, in year one. So this wasn't, okay, wow, we do this public health intervention and 10 years later, there might be a return. Those interventions, by the way, are super important, but they're hard to sell to a hospital CFO. This was something we could take to the hospital CFO and be like, do you want to, if you're in a value-based arrangement, or if you're a payer, like this is something you should be doing today. So I'll pause there and make sure that that answered the question of how do you get buy-in from the payers? You have to use an evidence-based model that is proven to thread the needle between the heart and the dollar sign. It improves outcomes for the people that you care about, but it also delivers financial returns for people who can fund it.
While waiting for a response to see if that answered the question and any other questions, what I'm saying, this seems like the ideal state. Like after all of the research, you've gotten these great outcomes that are publishable. Were there any leading indicators of things that you measured that were important to learning about this problem? And were there any things that were not important to collect at the earlier stages?
No, we went right for the RCT, and here's why.
Okay.
Like randomized control trials are not that hard to do. I think people put them on a pedestal and they're like, oh my gosh, like I'm going to need $1 million NIH grant. What is a randomized control trial? A randomized control trial is a coin flip. So first, when you're doing good science and good design, because I think that they converge, the first thing you do is like ask a lot of questions and then you form a hypothesis. So for us, it was like, what do you think works? Okay, then we have the hypothesis that like this intervention will move these needles. Then how do you test that hypothesis? The worst thing that you can do is a pre-post or a before and after analysis where there's 100 people, they all have super high rates of hospitalization. You do this intervention and then you see what happens. The reason that that's not a good idea, even though it's the most common study design out there, is that there's this thing, it's a statistical law of gravity. Things are always going up and down. Temperature in a room, hospitalization rates. So if you pick a group of people that has sky high hospitalization rates and do absolutely nothing at all, their rates will fall. There's
reversal to the
no
mean.
more ceiling, huh?
Reversal to the mean, just like all that. Gotcha.
Nice, Julia. Yes, exactly. So there's a lot of unfortunately, care delivery transformations out there that claim results that are just a statistical mirage. On the other hand, what is a randomized control trial? It's a coin flip. So you take the same pool of people, it could be people with high rates of hospitalization, but then you flip a coin and you say, you 50, go over here, like anyone who gets heads, go in this group, you're not going to get the intervention. And anyone who gets tails, you go over here and you do get the intervention. And then you do a quick experiment and you test it to see if the people who got the intervention have the outcomes that you're hypothesizing for. Designers do these all the time. There are, Leora Horowitz, who's a researcher at NYU, has written beautiful papers about, quick embedded randomized experiments that health systems can do to make good decisions. Because if you're using the randomized design, you're going to have actual data that is credible.
Great. So what I'm hearing is foundational research, have metrics, tie that to outcomes that are meaningful to repair. And it looks like we have Nicole with another question.
Yes, this definitely answers my question. I really appreciate it. When you presented this to hospital CEOs, Did you also do like a pilot program with them to prove out the value that you really can get these types of results with a very small population of their hospital patient base?
Well, thank you for that question, Naquan. Let me make sure I understood it. We did the randomized control trial with, I think the first RCT was like 400 patients. We did that experiment, and then we went and took that real RCT data to the health system where most of those patients were going and said, look at this. And it was not that hard of a case to make because you're coming in with such strong, credible data that, you know, that was, so does that answer your question?
Oh, it does. I see. So the population in the study were actually already going to that health system. So in essence, you've kind of proved out that this would work in your system.
The very first one, yes, yes. Now, you don't have to do that every single time, you know, you scale, because right now we're working with 70, you know, partner organizations across 20 different states. You can't be doing, you know, RCTs in every single time. Here's an analogy. You know, have you guys heard of statin medications or, you know, an aspirin or something like that? Those
Yep.
have been tested and proven in randomized control trials, like statins lower cholesterol. Cool. When I prescribe them to Mrs. Jones, I don't do another randomized control trial like just for my patient population. I'm like, this is an evidence-based intervention. You're going to take this for your cholesterol. So similarly, you know, I'm talking about the foundational work and our journey. Yes, in the very beginning, we proved it out, and then to scale it in our very first clinical program, which was the University of Pennsylvania, we said, hey, you know, these are clinical trial data for your own patient population. But at this point, it has become standard of care. And actually, it's unethical to do a randomized experiment of the impact intervention anymore, unless there's quite a lot of safeguards, because you can't deny people standard of care. It'd be like doing a randomized control trial of a statin.
Ah, gotcha. And how would you change the presentation of impact for a payer?
That's a great question. Let's take that as an opportunity to kind of go into the next slide, which is, you know, what are the secret sauces of an effective community health worker program, otherwise known as what do we do at Impact Care? We help organizations, whether they are payers, providers, community-based organizations, states, to basically get all of these secret sauces right. There's not just one secret sauce for a community health worker program. It's not just about hiring. You do have to get all of these components right in order to really build and to deliver the kind of outcomes that we demonstrated. So we actually take a pretty similar approach, regardless of whether it's a provider or a payer. There are some differences that mostly happen during the strategic planning stage. So whenever there's a new partner organization, just like community health workers would do with a patient, we meet the organization where they are. We say, you know, tell us about you. Like, what are your hopes and what are your dreams and what's keeping your CEO up at night and your CFO up at night? And we help them, you know, articulate what their vision could be for how a community health worker program could address those core business challenges. And we work backwards from that vision to a very operational plan. You know, we think about, well, what outcomes are you going to move the needle on? And what are your priority populations? And are you going to employ CHWs directly, or are you going to partner with a local community organizations to employ them? And what are their caseloads going to be depending on the problems that you're trying to solve and all of that. So a lot of the bespoke work happens during the planning stage. The next thing that we do is we actually help them hire the right people. And if we have time at the end, I'm happy to give some demos of how this works. But we have a group of people who do nothing all day long except for interview community health workers, and they're amazing at it. They can recognize that empathy and non-judgment and listening and reliability. And they can make sure that we're finding people from all of these different communities across the country who represent the lived experiences of the patients that they will serve. We then provide training and professional development. We have an app that has been built by community health workers for community health workers that takes all of our evidence-based workflows and interview guides and tools over the years and puts them in the hands of community health workers. and also allows them to do analytics for community health workers and their supervisors, so that they're able to do ongoing redesign and continuous process improvement. So let me pause there because I know that was a lot.
I would love to see a demo. If you have a video, I feel like you have some good content around the problem and actually visualizing what this program looks like on your website.
Spoken like a true designer. So let's do a demo. Let me just give me a quick second. You know what? I don't think I have the option to share sound.
If you drop a link in the, actually, I don't know. Do you want to try it, and then maybe a link in the Slack, and we can, or in the chat, and we can try to
unfortunately, the link appears to be disabled. I see the link, but it's disabled, and it's not on our, it's on our shared drive, so I can't.
Oh, it's okay. Well, we can find it and post.
Cool.
Hmm.
Okay, so let me start with, I won't be able to kind of show you this video, but I think, it is important for you all to try and watch videos, on our website or whatever, of true community health workers. What we do in, the planning stage, we talked about, but in the hiring, we have an app that allows community members in, any community that we go into, whether it's like Portland, Oregon, or, rural Appalachia. It allows those local community members to serve as recruiters for impact. And we ask them to basically, send us folks who who do good without being asked. And then we pay them for their referrals. So Joe, who's a public librarian in Portland, Oregon, can say, Brittany's amazing. I think she should apply. He texts her the link. She applies to be a community health worker. And we pay Joe $10 for the referral. If Brittany gets to the screening stage, we pay him $100. And if she gets hired by one of our partner organizations, we pay him $1,000. So it's a democratized headhunting service for this unique talent pool that allows community members to lift up their own natural helpers. It also is a real design, it's a fun design piece because it solves for grassroots mobilization and scale. You can launch, hundreds of hiring campaigns across the country using the technology, but they're word of mouth referrals fundamentally. So, and then live people will actually meet with Brittany and do these, validated interviews. It's not a checklist. It's like, behavioral role plays and things like that. But we're looking for key things that we know make a community health worker. We have training for community health workers, but also really critically for leaders. You can train a community health worker until they're blue in the face, but if their boss doesn't understand their job, they're not going to get very far. And it's ongoing. So, community health workers get 90 minutes a month of professional development. Leaders participate in a quarterly learning collaborative. There's, video content that's, been made by and for community health workers. So there's training. And then the last and most, I think one of the most critical pieces is the day-to-day workflows. So if you're a community health worker, you have all sorts of different situations that you find yourselves in. And there's, a manual that kind of lays out like the theory and day-to-day of being a community health worker, but critically also has these conversation guides for, oh, what do I say when I'm doing the outreach? And how do I actually meet people? And what do I say if they're in the hospital? Or what if they're dying, or what if they've just had a baby? So as a community health worker, I can follow these socio-behavioral science grounded evidence-based practices for how to bring out a story. All of that is embedded in a software application because that's what you have to do to bring this to life. And let me show you a quick peek of that. And the cool thing about this is that this has been designed, by and for community health workers. So as a community health worker, I can kind of come in, I see a client list. These are obviously, dummy data. This is not PHI. And it, this data can be pulled from the electronic medical record or from payer claims or lists. But when you ask community health workers to document in the EMR, usually you're like making them lose their magic, you know, because they're going to get over medicalized. The EMR is very want. If you know, instead take a look at this, like it's humanistic, you know, people can post selfies of them and their, you know, community, their patients doing things. They can pull down all of those evidence-based conversation prompts that comes in a pop-up. So you're not seeing that. They can type their note. They can do all of the normal things like save and edit. What they can also do is be very person-centered. So if instead of just doing checkbox, screen and refer, they can say, you know, Miss Will wants to reconnect with her mom. So that becomes one of my goals. And I can set a deadline for that. And, you know, I'm going to say like, I want to do that in the next 2 weeks. Awesome. And then I can project manage around that. I can say the first thing we need to do is write out a letter, you know, and I have my little checklist for what to do and I can check it off. And so it just helps community health workers stay organized. They can look at this and say, you know, who do I need to reach out to because I haven't, you know, like talked to people in a while, or like who does my manager need to run the list on and like supervise with me, and they can see all of the metrics there. So let me pause because, you know, there's just a lot more to talk about here, but there's a lot of layers of solutioning, you know, that are baked into that application.
To zoom back out though, there was foundational research and listening that gets you some of these insights that then it's not around like community health workers, it's the solution so much as the actual implementation of that and being able to get through the to some design something on the edge that hasn't been done and implement it in a way that hasn't been done rather than proposing a new idea without that infrastructure. And there was a technique in kind of biodesign around this approach, which has been to look at that problem or the framing and to move upstream or downstream or zoom out or zoom in and find different ways of looking at the same solution that's been proposed many different times. So thank you for sharing that demo. I think we may have time for one more question if someone puts in the chat now, but I think we can share screen and kind of wrap up if that's okay. Akash, do you want to share screen or should I?
Yeah, sorry, let me share this. It's gonna pull it
Good. Zoom logistics. Okay. So I guess I can verbally summarize again. That was impact around community health workers are trustworthy and lived experiences. I think it gives people like a mental model around like how to approach this discovery phase over this month while coming up with their application. Listening people to come up with those original hypotheses, how that gets translated into RCTs and outcome data to find the outcomes that matter to different buyers. And then all of the implementation and solutioning is kind of the last step after doing a lot of that upfront focus on the problem. If we can go to the next slide. We have more perspectives on what it looks like to approach different problems in social determinant areas or around access to care. So we have Nikita with Fortuna Health, which is kind of like a TurboTax for Medicaid. Colby with Pear Suite, and I think it's another community health worker related approach. And then Jack Schaefer around MetaCircle and access to medications. We're also doing a team formation support session, and we want to hear from people interested in applying for the challenge. There's a poll on Slack for people to fill out there. It's just to choose times you're available. And then lastly, we'll have 1 week of speakers around different perspectives of people that are looking more broadly at the health ecosystem around what they're seeing. So yeah, thank you for everyone that came today and for Dr. Kangovi for sharing a lot of great stories and visuals on what good looks like in this space. Thank you. Oh, wait, unless we have a Q&A question here. We shared the link for the challenge. Okay, we can do that. Okay.
Thanks, guys.
Thank you very much. Oh, sorry. And the special thanks to our partners that we did not end on. My bad. A lot of people that make this possible. I think I ended it a little early, but yep. Thank you all. Bye.